Hello. Today we'll be discussing the Genecept Assay March 2017 report updates. I'm Dr. Russell Amato, Medical Science Liaison for Genomind, and I'll be walking you through the Genecept report changes. This presentation and the Genecept Assay may include discussion of drugs that are not approved by the relevant regulatory authority, including the U.S. FDA, or the use of drugs not approved for specific indications, also known as off-label use. In order to be familiar with the potential benefit and potential harm of any medication, prescribers should be familiar with the indications, precautions, and warnings of drugs used. Please consult the manufacturer's prescribing information. As some of you may already know, Genomind is a personalized medicine company that is bringing innovation to mental health through genetic testing. The Genecept Assay is our main service offering, and it is a comprehensive test developed in our clinical laboratory. It provides licensed and prescribing clinicians a tool to use based on their patient's own genetic information that may help guide personalized treatment selection for mental illness. Our testing is used on the order of a prescribing clinician. The process to order the Genecept Assay is a fairly straightforward one. It begins with a cheek swab conducted at the clinician's office. A cotton swab is rubbed along the inside of the patient's cheeks and gums for about 1 minute. This swab gets labeled with a unique identifier and shipped to our Genomind lab in King of Prussia, Pennsylvania. Once the sample is received, our lab performs the genetic analysis and creates the personalized Genecept report, usually within 3 to 5 business days. The report can be accessed by the clinician through our HIPAA-compliant online clinician portal, and if preferred, the report can be transmitted via fax as well. Once the clinician views the report, they always have access to a member of our expert Genomind clinical team to discuss the clinical implications of the genetic variants found, as we reviewed today. While our clinical team does not and cannot provide medical advice for treating specific patients, they are experienced at understanding genetic variants and what the literature tells us those can mean for patients. As a result, our team can help clinicians better understand the information in each report so that they can determine the best course of action for their patients based on their patient's medical treatment and history. We are happy to announce that we have expanded and improved our Genecept Assay results report as of March 27, 2017. The test still includes the analysis of variants in 18 different genes, which were selected based upon hundreds of studies showing that variations in these genes can inform treatment decisions in psychiatry. Our improved report now includes a genetic analysis of 20 additional medications in the drug interaction summary. In addition, we have made several updates to the report language and interpretations that are more consistent with the current literature. Based on user feedback, we have also enhanced our report formatting to provide more clarity around how these genes may influence treatment outcomes. Thanks for joining me in reviewing the enhancements to the Genecept's results report. Let's start by looking at some of the medication additions to Genecept. 2 antidepressants that have made it to the report are nifazodone and milnacipran. Nifazodone is a unique antidepressant in that in addition to blocking serotonin and norepinephrine reuptake, it also modulates serotonin 1A and 2C receptors. It does not rely solely on the serotonin transporter for its efficacy, and Genecept lists it as a therapeutic option when an SLC6A4 variant is present. Milnacipran is an SNRI that is currently only indicated for fibromyalgia in the United States. It is, however, approved as an antidepressant in many other countries, and a 2014 Cochrane analysis showed it to be similar to SSRIs or tricyclic antidepressants in regards to efficacy for depression. As far as anxiolytic medications, 3 new benzodiazepines, clorazepate, oxazepam, and temazepam, have been added to the new report. These benzodiazepines are minimally influenced by cytochrome P450s, which make them somewhat unique when compared to other benzodiazepines. A non-benzodiazepine, propranolol, has been added to the report as well. This has been shown to be no different than the benzodiazepines for some anxiety disorders, and other recent data link it to improvements in some core autism symptoms. Lastly, several sleep medications have been added to the report. Insomnia is often comorbid with depression, and clinicians are frequently treating sleep disturbances along with depressive symptoms. The Z drugs, zolpidem, zaloplan, and azopiclone, are very similar in their mechanism of action, and all are metabolized by the CYP3A4 pathway. Ramelpion has a different mechanism as it is a melatonin agonist and goes through the CYP1A2 enzyme. Suvorexant is the newest approved sleep medication, and this is a member of the orexin antagonist class of drugs. It is primarily metabolized by CYP3A4 with a minor contribution of CYP2C19. Continuing our introduction of new Genecept drugs, we will now look at some additional medications used for pain, substance abuse, and weight gain. Ketorolac is the only new NSAID or nonsteroidal anti-inflammatory drug that has made it onto the March 2017 update. The drug label cautions that it should only be used for short-term severe pain, so about 5 days or less. Meperidine, tapentadol, and buprenorphine all modulate opioid receptors and are all indicated for varying types of pain. Meperidine and tapentadol are both mu-opioid agonists, which accounts for their analgesic effects. They both can inhibit norepinephrine transporters, which may be part of their therapeutic impact. Meperidine has a toxic metabolite and potentially dangerous interactions with CYP450 inhibitors and has been flagged as a risk drug by the American Pain Society. Tapentadol is very similar to tramadol, with one difference being that tapentadol is minimally affected by CYP450 enzymes when compared to tramadol. Buprenorphine is a mixed opioid antagonist agonist and is indicated for the pain management as well as for opioid dependence. For maintenance treatment of opioid dependence, the combination product Suboxone, which contains buprenorphine and naloxone, is indicated. Buprenorphine is metabolized to some extent by CYP3A4. A study in 2014 associated buprenorphine response for opioid addiction to the OPRD1 gene. These results were only found for female patients, and this study requires replication. Naltrexone is considered a therapeutic option for both opioid and alcohol dependence, and the drug has been added to the report due to its association with OPRM1 gene. We will discuss this in further detail later. Metformin and lorcaserin are two agents that may be effective in the treatment of antipsychotic-induced weight gain. Second-generation antipsychotics are valuable medications in the treatment of psychosis, depression, bipolar, and anxiety disorders. However, some can cause significant weight gain. Metformin is considered one of the first-line treatments of AIWG, and in 2016, the FDA changed guidance on who can safely receive metformin. The link to the FDA announcement can be found on this slide. This will be expanded upon later as we discuss the interesting mechanism of action of lorcaserin. The last addition to Genecept is tolcapone, a COMT inhibitor which may be useful in improving cognitive symptoms in difficult-to-treat bipolar or schizophrenic patients. This slide presents a summary of the new medication additions. Take notice of the cytochrome P450 pathways of these drugs, which is now identified in the Genecept assay. This slide also summarizes some of the new drugs, and we will go into more detail in regards to naltrexone, metformin, lorcaserin, and tolcapone. For now, though, let's discuss some of the language updates that we have made with our Genecept report. We will start with SLC6A4, the serotonin transporter gene. If you've used Genecept before, you are aware that the SLC6A4 gene has been associated with differential response or remission rates to SSRIs. This differential response rate is supported by meta-analyses by Soretti and Porcelli. Data taken from the STAR-D patients and also a meta-analysis by Cato also associates the S or LG allele with increased rates of side effects with SSRIs. What seems to be most consistent in these trials is that there is a clear difference in response rates between the extremes of LL genotypes versus SS genotypes. LLs are generally the best responders to SSRIs, while SS are poor responders with an increased odds of response or remission in the 50% range for LL individuals, according to Porcelli. In order to make Genecept more consistent with this, we now identify individuals with the LL type as improved responders to SSRIs. This is in regards to response rate and side effect burden. Carriers of a single S or LG allele do not necessarily have altered response or remission rates to SSRIs, but side effects are often more common. The 2007 study by Hugh et al. Concluded that carrying even one of these S or LG risk alleles was a strong risk factor for SSRI side effect burden. It is probably best to think of these genotypes existing along a spectrum, with LL being associated with the best response to SSRIs, SS being associated with the lowest response to SSRIs, and heterozygotes being somewhere in the middle, while keeping in mind that heterozygotes and SS seem to suffer the most side effects from SSRIs. We have also added language in Genecept around stress-induced cortisol fluctuations that are associated with SLC6A4 genotype. Several studies have shown that cortisol levels following a stress test, like the Trier test, for example, are higher in short individuals compared to carriers of the long gene. This can help clinicians elucidate one of the mechanisms behind depression and anxiety, and patients find it useful to understand that there is a physiological basis to their condition. Here is a summary slide of the SLC6A4 gene, which includes many of the points just discussed. Just a reminder about the different alleles of the serotonin transporter gene, there is a long and a short version of the gene. The short version is literally shorter, with 44 fewer base pairs. Within the long gene, you can also have a single base pair substitution of a G for an A. Think of the LG allele as functionally equivalent to the S gene. Both S and LG are associated with increased rates of side effects to the SSRIs. We will now switch gears to second-generation antipsychotics, or SGAs. Don't let the name fool you, because much of the time they're used for conditions other than psychosis. Depression, bipolar, anxiety, or autism, for example. While these medications are very effective, one of the major drawbacks of this is antipsychotic-induced weight gain, or AIWG. While some of these drugs are worse offenders than others, it is often a balancing act between treating mental health symptoms and minimizing AIWG. To this end, we have added two anti-obesity medications to the panel, Metformin and Lorcaserin. A 2010 meta-analysis of drugs used for AIWG identified Metformin as one of the most effective medications. In addition, the FDA changed the label of Metformin in 2016 in regards to using it with mild to moderate kidney impairment. The full guidelines can be found on the FDA website. You can also see the product full prescribing information for Metformin. Lorcaserin is one of the newer weight loss therapies on the market and has been shown to produce significant weight loss and also maintain that weight loss over 2 years. One interesting aspect of lorcaserin is that it is a serotonin 2C agonist, which acts directly in opposition to many weight-inducing antipsychotics, which are serotonin 2C antagonists. Continuing with our discussion of second-generation antipsychotics, we will now discuss some recent literature linking SGA response rates with the COMP genotype. The forest plot of this 2016 meta-analysis shows the differential response rates to SGAs when comparing COMP-MET-MET to VAL allele carriers. Odds of response were 54% greater in schizophrenia or schizoaffective patients when they had the COMP-MET-MET genotype. One of the more difficult to treat aspects of mental health syndrome are the comorbid cognitive deficits. Similar to response rates with SGAs, it also appears that cognitive symptoms improve to a greater extent in COMP-MET-MET individuals following antipsychotic treatment. Studies by Woodward et al. And Weckert et al. Showed a significant difference in cognitive symptom improvement when comparing COMP genotypes. While these studies are generally small, the direction is the same across several studies. The COMP-MET allele load contributes to improved measures of working memory or verbal fluency, whereas COMP-VAL allelic load appears to be a risk factor. Similar to the Woodward and Weckert studies, working memory tasks were improved in COMP-MET-MET individuals following olanzapine therapy when compared to VAL carriers. And again, the VAL-VAL individuals had decreases in verbal comprehension and working memory following antipsychotic therapy. The study was encouraging since it had a sample of 276 patients, and the difference between VAL-VAL and MET carriers increased as doses of these medications increased. In summary, Genecept now reports SGAs as therapeutic options for COMT-MET-MET individuals, as they appear to be more likely to respond and also achieve the greatest improvements in cognitive symptoms. Tolcapone is a COMT inhibitor and is currently only approved for adjunctive therapy of Parkinson's disease. Considering its mechanism at the COMT enzyme, researchers postulated that this drug would have greater impact on the COMT-VAL-VAL patients than the COMT-MET-MET patients. Keep in mind that COMT-VAL-VAL patients have the high-activity COMT enzyme, and this implies that a reduction in COMT activity via a COMT inhibitor may be more beneficial in regulating synaptic dopamine in these individuals. Several small studies suggest that COMT-VAL-VAL people do actually have greater improvement in cognitive domains following tolcapone therapy. This study by Farrell from 2012 highlights this association. In both tests of working memory, both the 2-back and 3-back test, MET-MET individuals started with higher working memory scores compared to VAL-VALs. This situation was reversed once tolcapone was initiated. An additional study in 2008 showed similar results with the VAL-VAL group showing improved reaction time following tolcapone, but no difference in MET-MET group. Further studies with larger sample sizes are certainly needed, but these are promising early results for the frequently difficult to treat cognitive symptoms of psychiatric disease. It should be noted that tolcapone carries a black box warning for liver failure. Tolcapone Advisory Panel concluded that this was rare, especially when monitoring parameters were followed. Another concern is access to this potentially therapeutic medication. Recent cost increases and its use for off-label indications may place it out of reach of many patients. In any case, it provides an interesting model for identifying genetic variants which may interact with certain drugs based on unique drug mechanisms. There is quite a bit of media coverage in regards to the current opioid epidemic in America. There is extensive research being done to identify biomarkers for dependence. We can currently identify some risk factors for opioid dependence, such as family member diagnosed with opioid abuse or non-opioid drug abuse history. Genetic risk factors are part of this puzzle, and much of the research is related to dopamine gene pathways, which influence the reward system. A 2010 meta-analysis by Chen et al. Of 4,608 patients concluded that having a deletion allele at the DRD2 gene increased the risk of opioid dependency by 27%. Keep in mind, this is in no way diagnostic and is only a piece of the puzzle when it comes to opioid dependence and treatment. The updated Genecept report identifies patients who you may want to exhibit caution when prescribing opioids, so you can incorporate this information into the risk-reward analysis. Though there has been great attention paid to opioid use disorder, alcohol use disorder is a far more common condition. As such, we have added naltrexone to the Genecept report in regards to alcohol use treatment related to the OPRM1 gene. A meta-analysis from 2012 associated the G allele at OPRM1 with almost 2 times the likelihood of response to naltrexone for the treatment of alcohol abuse. Additionally, Anton and colleagues found that 87% of alcohol-dependent carriers of the G allele had a good outcome when treated with 100 milligrams of naltrexone compared to AA carriers, of which approximately only 55% had a good outcome. Therefore, G allele carriers may respond better to naltrexone for the treatment of alcohol use disorders. We will now shift gears to some of the changes around pharmacokinetic gene variants. The previous edition of Genecept listed cruciferous vegetables as a potential inducer of CYP1A2. While this is true, you need to eat quite a bit of these before it becomes close to being clinically significant. The last thing we want to imply is that it is unsafe to eat broccoli or Brussels sprouts with some medications, so this language was removed from the report. Please continue to eat your veggies. We did, however, update Genecept to include marijuana smoke as an inducer of CYP1A2. The combustion process releases aryl hydrocarbons, and these are the compounds that result in induction of CYP1A2. As a follow-up to that, cigarette smoke or marijuana smoke can induce CYP1A2, but nicotine patches or gum are unlikely to induce this enzyme. The enhanced Genecept report also tries to make it clear that much of the clinical variation of CYP1A2 is due primarily to induction of this enzyme. In the drug interaction summary, we have added the phrase "with inducers" to the column for decreased serum levels of identified drugs. We want to emphasize that clinical changes in serum levels of CYP1A2 substrates is probably only clinically relevant when that enzyme is induced. Smoking or carbamazepine would be good examples of inducers. From a genetic standpoint, the STAR1F alleles of CYP1A2 appear to be the most inducible versions of this gene, and Genecept identifies those. Bupropion is one of the more commonly prescribed antidepressants and is unique in that much of its effect comes from its metabolite as opposed to bupropion itself. Drugs that follow this sequence of metabolism can be thought of as prodrugs, or drugs that become more active once metabolized. Bupropion is metabolized by CYP2B6 into hydroxybupropion, and although hydroxybupropion is less pharmacologically active than bupropion, serum levels of hydroxybupropion are 20 times higher than the parent compound. So while technically not a prodrug, it can practically be considered one, since much of its effects are due to hydroxybupropion. Bupropion will join venlafaxine, codeine, and hydrocodone as the other prodrugs on the report. It should be noted, however, that codeine is the only true prodrug, while the other three are pseudo-prodrugs. It should also be noted that Vyvanse or lisdexamfetamine is a prodrug, with one major difference being that it does not require CYP450 enzymes to be activated. This study by Labe in 2014 corroborates hydroxybupropion's role in antidepressant effect. Higher levels of serum hydroxybupropion correlated with measures of improvement on the CGI scale. A 2013 study for smoking cessations showed similar outcomes where higher hydroxybupropion levels resulted in greater incidence of smoking cessation. The authors of this smoking study concluded that CYP2B6 had an impact on hydroxybupropion levels and that increasing bupropion levels in CYP2B6 slow metabolizers may be required to achieve adequate hydroxybupropion levels. Staying focused on CYP450 metabolism, we have added some new terminology to the Genecept report involving drugs that go through multiple CYP pathways. Let's use sertraline as an example of a medication that goes through several CYP450 enzymes, including CYP2C19, 2B6, 3A4, and 2C9. Since multiple pathways are involved, any genetic mutations at any single enzyme is unlikely to cause significant changes in serum levels. We are calling this multi-CYP on the new Genecept report. Lorcaserin would be another example of a multi-CYP drug. This differs from a drug like L-methylfolate, which completely bypasses CYP450 metabolism and is designated with a dash mark. This provides further clarity around drugs with complex metabolism mechanisms. In addition to the inducers phrasing in the drug interaction summary, we have also added a notation for weight gain risk related to second-generation antipsychotics and the MC4R and 5-HT2C genes. The checkmark from the previous version of Genecept did not do a sufficient job in identifying weight gain as the primary side effect associated with MC4R and 5-HT2C. We have added a weight gain notation to clarify that these genes are only predictors of weight gain and have no significant impact on efficacy or other side effects. Looking at this report example, one will notice that not all of the SGAs are associated with weight gain equally, and some are relatively weight neutral. Asenapine, brexpiprazole, cariprazine, lorazepam, and ziprasidone are considered the agents least likely to cause significant weight gain and are stratified as such in the new Genecept report. I hope you found this webinar on the Genecept Assay report updates informational. The expanded Genecept Assay is designed to help reduce the time, expense, and struggle of finding the right treatment by trial and error. With the expanded test, the Genecept Assay now covers more than 20 drug classes, 122 medications approved by the U.S. Food and Drug Administration, 18 clinically validated genes, and 97% of medications used to treat depression, anxiety, bipolar disorder, schizophrenia, ADHD, and autism, and offers a comprehensive coverage of pain medications. Any clinician with prescriptive authority may order the Genecept Assay. There are two options for ordering the test kit to use with patients. One, through the Genomind homepage at www.genomind.com, or two, through the Genomind customer service line at 877-895-8658. Representatives are available Monday through Friday until 7 p.m. Eastern Standard Time. Thank you for your interest in Genomind and the Genecept Assay. We hope this webinar was informative, and thank you.